Okay, it looks like it's 11 o'clock, so we'll get going. Welcome to Stanford's quarterly DBS support group, Deep Brain Stimulation Support Group. Group meets in March, June, September, and December on the third Thursday of those months. Our next meeting will be on December 17th at 11, probably, I'm guessing, virtually, just like this one. The group was set up to provide information for anyone interested in learning about deep brain stimulation as a treatment option for Parkinson's. Today's presentation is being recorded. Everyone who's registered will receive a link to the recording when it's been posted within a week, as well as to a brief survey about today's program. Just had Dr. Henderson join us. If you'd like to join the reminder email list for this group, I've included a link to my email address in the chat. We only use the list to send reminders about upcoming DBS meetings. So don't have to worry about that. The group's offered as part of Stanford's Parkinson's Community Outreach Program. I have provided a link to our newly updated website in the chat. And as part of that group, my colleagues and I provide information to anyone in Northern and Central California wanting to learn more about Parkinson's and Parkinsonism, atypical Parkinsonism. We also provide referrals in our service area in Northern and Central California to those seeking a neurologist, a movement disorder specialist, physical therapist, occupational therapist, speech language pathologist, psychologist, or social worker. And I've also provided a link to our contact form in the chat. So please feel free to reach out to us if we can help you with any information or referral services. And please understand that applies to anyone, no matter where the person with Parkinson's is seen. Obviously, Stanford is a great place to come for Parkinson's care, but we also work with people at Kaiser and UCSF and Sutter and independent people who are seen by independent neurologists. I see we have Dr. Henderson is with us now. So I would be happy and delighted to introduce Dr. Jamie Henderson, who's our presenter today.
Yeah. All right. Hi, everybody. Nice to see everyone, or for everyone to see me, I guess.
Everyone to see you, yeah. So actually, I was just finishing the introduction. Let me just quickly finish that. Well, actually, you know what, since you're already on, one thing I did want to remind everyone in the chat, I did include a link to more information about Dr. Henderson. You'll see quite a bit today, but I also included a link to your profile. So actually, since we already have you there and video is working now, or at least we can see you, why don't we have you just start right out.
Sounds good. All right. Thanks very much. And let me see if I can share my presentation. Hopefully this will work without a hitch.
Hey.
Good. So, all right. So today I'd like to take a little bit of time to talk to everybody about some of the latest updates in deep brain stimulation. I know that Dan Kramer, who was my fellow this past year, talked to you guys just a few months ago. So much of this may be a bit of a repeat, but whereas he had a chance to answer a lot of questions, I'm hoping that maybe providing a little bit of a visual for some of the things and showing you a little bit about the steps that we go through for surgery, and then being able to answer questions at the end. I should be able to hang around for a while in order to do that. So looking forward to it. All right, so what is it that we're talking about with deep brain stimulation? Well, for us as neurosurgeons, we have to hit a very small target about the size of a large lima bean, if we're talking about the subthalamic nucleus, that's deep in the brain with an electrode that's about the size of a pencil lead. So this is without really any sort of image. So we can use imaging during surgery, but it's not like an open neurosurgical operation where you can look at the structures that you're operating on. You have to do this all electronically and all through computers. And so how do we do this? Well, there's a technique called stereotaxis that was invented really at the turn of the 20th century, so right around the late 1800s, the early 1900s. This was originally developed for surgery in animals, where a device called a stereotactic frame is placed on the head, and then images are acquired where you can look at the relationship of that apparatus to the brain based on the imaging. And it allows you to then very precisely position an electrode into the brain or to do various different types of interventions deep in the brain. Up until about the 1940s, this really wasn't able to be used very well in people because there were no imaging modalities. You couldn't necessarily relate the actual brain to the stereotactic apparatus like you could in animals whose brains are all the same. So, so really required MRI and CT scanning to be able to really bring this into the modern era. And this is this is a photo of a patient having a head frame applied, which, you know, obviously is not a particularly comfortable procedure. It's it requires putting pins into the skull. It's quite uncomfortable, and you know, people do get used to it after having the frame in place for 10 or 15 minutes. But this was always something that I looked at during my training and my residency and said, you know, it'd be great if we had some way that was better than this, where, you know, we didn't necessarily have to have a patient during surgery sort of in this claustrophobic box and having to you know, sort of be supported in a position that wasn't particularly comfortable. Now, obviously, many patients have undergone DBS with an apparatus just like this and have done so very successfully. And it's still the standard technique of many neurosurgeons, including one of my colleagues at Stanford. But my vision was to say, well, you know, maybe we could do away with the frame, and maybe we could have a procedure in which you didn't have to be tied down, where you could move around, shift your position during surgery. Because the surgery is done with people awake, it's often advantageous to be able to just sort of move and shift, and it keeps people, I think, much more comfortable during the operation. So, you know, I think there are several advantages to it. It's during surgery, we can have patients mobile in case you want to evaluate particular things like neck movement or other things. I think personally, I think it's more comfortable. I've had a few patients who have had one side done with a frame and one side done this way, and all of them have said that the frameless version of it is better. One of the nice things for me as a surgeon is that it allows us to take the imaging away from the surgery. So as I was explaining previously, when you have the stereotactic frame attached to your head, you have to undergo the imaging with that frame attached. With the frameless system, we can apply the markers. We still have to have some sort of a marker in order to show the computer where your head is in space, and I'll explain that in just a little bit. But we can do that all the day before. So this allows us to do our imaging all before surgery. So I can spend the afternoon or the evening prior to surgery planning the operation in a very leisurely way, getting things tuned in exactly right. So we're not under the time pressure of a morning in the operating room to try to get everything planned up. And I think this also leads to you know, a more relaxed way to do the operation that I think can improve outcomes. And it also means that the amount of time that you have to spend in the operating room or with the frame on your head getting imaged or other things can be cut down by quite a bit, maybe even up to several hours. So I think it's got a lot of advantages over a stereotactic frame. So the steps to doing a frameless DBS operation, and this has been my standard technique now for over 15 years. We first started testing this, I and a couple of colleagues who were really the people who worked with the original companies to develop this device. We did our first study in 2004 and published the results. The results ended up being published in 2006 in the Journal of Neurosurgery. Since that time, this is how I've done all of my DBS cases. So I haven't done any, I've done very few with a stereotactic frame, just in odd circumstances. So how do we do this? Well, we first obtain MRI imaging. So when you come in for your preoperative assessment at Stanford, we would make sure that you're a good candidate for surgery. We would then obtain these MRI images that let us see the structures that we're aiming at deep in the brain, as well as the blood vessels that we'd like to avoid. Then the day prior to surgery, we put markers in. So unfortunately, there's no way around still having to do local anesthetic injections and putting little screws that go into the skull, which they go about 4 millimeters in, and they're quite small. And I think there's less discomfort to that than there is to a stereotactic frame because you don't have the pressure on the skull. But that's done the day before surgery. We then wrap your head up with a cloth bandage or with a gauze bandage, send it on to the CT scanner, and we get a CT scan. So once we've got the MRI and the CT scan, we use the MRI for the tissue definition so that we can clearly see the targets in the brain and avoid the blood vessels that we need to avoid. But the CT scan gives us those markers, and those markers are, again, what allow us to take the plan that I do ahead of time and implement it on the day of surgery. So then on the day of surgery, which is the following day, there are 3 major steps that we go through, and I'll go through each of these in turn. The registration step, where, as we said, we tell the computer where your head is in space. Microelectrode recording, which we use to try to verify our target placement so that we know that we're in just the right part of the brain. And then finally, placement of the DBS electrode and testing that out. So I'll go through each of these steps briefly. I don't want to spend a lot of time on this. This is, many of you, I'm sure, are already pretty familiar with all this. Many of the patients at Stanford and others that I've had the opportunity to work with are extremely well informed. So this is probably review for most of you, but I think it's worthwhile going through it anyway. So the reason we get the MRI scan without any sort of markers or anything in place is in order to try to minimize distortion. MRI is a magnetic imaging modality, which means that if you have any kind of metal, that it can distort the images. And we need for the MRI images to be as close as possible to a one-to-one relationship with what's real. And a warped image is going to make us off target. So we want to try to minimize the distortion that we get from the MRI scan. The CT scan we get with the markers because CT scan is optimally accurate. It represents precisely the situation. It doesn't suffer from the types of magnetic distortions that MRI does. So by fusing those 2 different image modalities together, it lets us use the best of both worlds. So the good tissue definition from the MRI with the high accuracy of the CT scan. So this is the fiducial placement. Again, as I said, we still have to, unfortunately, do a minor procedure with local anesthetic and put these markers into the skull. They're, again, as I said, little screws that are about 1 centimeter long and penetrate about 4 millimeters into the skull. This takes about half an hour. Interesting story about this patient. This is when I was still at the Cleveland Clinic. This was my very first patient to ever undergo a frameless stereotactic procedure for Parkinson's disease. She actually, she had to wait a little while in order to get it done because we were still sort of refining and perfecting the technique, making sure that it was absolutely accurate, which we discovered that it was, and then she could have surgery. So why weren't we able to do her operation with a stereotactic frame? Well, you can see from the picture on the right, her neck. So she had a spinal deformity that her neck was in a fixed position, and it was nearly impossible to have her in the MRI scanner because we had to sort of prop her up in order to get her head into the scanner, and it would have been impossible to do this with a stereotactic frame. She wouldn't have fit in the scanner. So for her, it was actually a necessity to do this. And interestingly enough, she many years later contacted me, and she had moved to the Bay Area and she was still doing very well. So I saw her back for her battery replacement many years later. So this is, for some patients, this is really kind of the only way you could do the procedure. Once we've gotten the CT and the MRI scan, we fuse them together on the software. And so this is an example of what that looks like. On the left is the CT scan, and on the right you can see the MRI scan, which is sort of a different colored gray, where you can make out a little bit better the differentiation between the gray matter and the white matter. And what you can see on the bottom is this is the red, which is the CT scan, merged onto the underlying gray, which is the MRI scan, and you can see that it's a very good registration between those two. So once we've got that MRI CT registration done, then I can sit down at the workstation and carefully plan out where our targets are. And we have a lot of different tools that are available for this. This is the surgical navigation platform that we routinely use, called the Stealth Station, and allows us to do all sorts of interesting things, like we can false color the various areas to sort of make the nuclei pop out. You can see this is a subthalamic nucleus target, and you can see that the subthalamic nucleus is sort of highlighted in red. There's an atlas superimposed on it that allows us to better delineate the edges of the target. And then there's a coordinate entry area where we can precisely enter the coordinates that we want and read those out in real time. So I can spend 30 to 45 minutes, which is usually about the time that it takes to plan one of these operations the day before. And then the first thing in the morning, we're ready to go, and we can get started right away when people show up. So then once we get to the operating room, then the next stage is something called registration. So here you can see one of those little markers in the front, and I unfortunately don't have a pointer, so I can't show you, but then there are those two other sort of cone-looking devices. Those are little protective covers that we've previously, when we first started doing this procedure, we thought, well, maybe they would help to prevent any sort of blow from or a bump from dislodging the markers. But what we discovered is that they just cause people discomfort, so we stopped using those. But the job that we now have to do is to say, well, okay, now we know where those markers are on the imaging study. So, and we know where they are on the patient. So here's those same markers on the reconstructed CT scan. So we now say, okay, how do we match those markers to the CT scan? And the reason for this is because I've done all of our planning on the CT scan. So we now have to translate that planning into real life. This is the step that makes that happen. And we do this by touching each one of these markers with an instrument. You can see I'm holding that instrument that has reflective spheres on it. There are infrared cameras that each of which have an infrared emitter around them, and the infrared light leaves the camera, bounces off those spheres, and comes back to the camera. And each one of those spheres looks like a circle. And by calculating the center of that circle, and by knowing the geometry of the instruments, we can tell exactly where that instrument is in three-dimensional space to a very small accuracy, something about 1/4 of a millimeter. So it's extremely accurate. And then you can see the device that's attached to the head with the strap, and that's a reference. So the second part of this is not only do we have to know where the head is in three-dimensional space, but we also have to know what the relationship of those markers are to the head. And the only way we can know that is to track the head. Otherwise, we just know where things are in the operating room, and that's becomes useless if your head moves. Then the registration goes out the window. So that's why we have to have a reference attached directly to the head in some way. This is just this is a device that we just place gently on the forehead with a strap that holds it in place while we do this initial registration step. Once we've done that, then every time I move that pointer on the head, an identical pointer moves on the three-dimensional reconstruction of the scan in the Stealth Station, so that I can very precisely locate exactly where that entry point is that I had planned out the night before. So once we've done that, then we make our incision and place this plastic tower. The burr hole here has been made for the surgery, and then this tower provides the platform that we can mount everything else on. And so Here you can see the platform is attached. There's a reference that's attached to that platform that has those reflective spheres on it. And so now what I'm doing is going back and touching each of those markers again, as we previously did, but now because everything is very rigidly attached to the skull, it actually ends up being even more accurate than a frame. A stereotactic frame has upright posts that attach to the skull. And even though it's a very rigid construct, there's still a little bit of movement possible between the head and the frame itself because there's flex in those posts and in the pins. Whereas here, everything is directly attached in very close proximity, so there's very little flex or change in the relationship of the localization device to the actual target deep in the brain. So this is actually proven to be even more accurate than a frame. And then this just shows pointing back to each of those markers and just showing the kind of accuracy that we can achieve. You see the red dot that's in the middle of the fiducial marker there, and that gives you the and it just shows you that it's quite precise to really less than a millimeter, because those are very small, as you can see, very small markers. Okay, so then once we've done that, once we've got everything registered, then the next phase is alignment. So what I'll now do is take an alignment device and put there's a top that goes on that tower that fastens down with screws, with plastic set screws, and then lets me align to the target that I had chosen the night before. So then all I have to do is kind of take this aim point and move it with a rotate and a sweep sort of motion in order to align that aim point with the target that we've selected the night before. So once we've done that, then everything is locked in place. And as we go down that trajectory, then we should encounter the targets that we had planned on encountering. Missing blood vessels, going through the appropriate part of the brain that we need to relieve symptoms. And this is what the whole device looks like once it's completely assembled. So what you see here is the tower attached to the skull, the aiming device, which has been attached to the top, and then on top of that aiming device is a microdrive. It's very lightweight, very accurate. There's a calibrated scale that lets us tell exactly how deep we are in the brain, and we can control that depth to less than a millimeter, and we can advance that. We can advance the microdrive by microns at a time, and you'll see the red cable which is coming off the electrode, and then a ground wire. So those are the two signals that we then feed into our amplifier system in order to listen to the brain cells deep in the brain to be able to tell whether we're in the correct target. So during the recording procedure, we have a very, very small, very fine electrode. The ones that we use are made of platinum and iridium alloy. It's the tip of that is very fine. It's 10 microns, which is 1/100th of a millimeter, so a very, very small, tiny tip. And that lets us get very close to the brain cells and identify their different firing patterns. So it's the STN or the GPI or any of the targets that we go to are very characteristic. You can tell quite well when you've entered the target, whether you're in the correct part of the target, because you're looking for cells that are driven by joint movement, which is your optimal target. So, so what we're doing now is to say, well, you know, we need to get to this part of the brain, but we want to go even finer scale, right down to the level of the individual brain cells or neurons, and listen to each of those guys individually with these microelectrodes. And so this is sort of the kinds of recordings that we get. And what I'll show you here in a minute is how we use this system. And this is actually our first generation system. We now have a new one where we've taken this entire huge tower, which stands about 7 feet tall, full of electronics, and compressed it into a little box that attaches to a laptop and allows us to record those signals. And you can see an example of those signals on the right side. So what I'm going to show you next is a video from the operating room. So Dr. Bronte Stewart, who's the neurologist who works with me, is going to be manipulating, or is going to be taking the hand of a patient that I'm working with. And this is in a target called the thalamus, which we often use for tremor, particularly essential tremor, but also sometimes tremor-dominant Parkinson's disease. And what she's doing is taking a paintbrush and she's stimulating each of the fingers, the palm of the hand, in various different spots. And what you'll notice is that when she brushes the thumb with the paintbrush, you'll hear a change in the sound of the background noise. And what that is the brain cells responding to that touch. So I'll let that play and hopefully you guys can hear it okay and see it okay. So you see there with the thumb, none of the other fingers. So as you saw, as Dr. Bronte Stewart was brushing the thumb, we now know that we're in the thumb area of the thalamus. So we can get very precise. We can know exactly where we are, whether we're in the area for the face, the arm, the leg, and adjust our targeting accordingly if we need to make other passes through the brain. We can also find tremor responsive cells, and we frequently find these in Parkinson's disease as well. So there you saw the tremor that was synchronized with, you heard the cells synchronized with the tremor and saw the traces. So we can use a lot of different strategies to map out this target. Our main one is to try to move arms and legs around to try to find the movement-related cells in the brain. And we can make several passes in order to try to get the best target in terms of being more for upper extremity versus for lower extremity. So we can move things around until we're in just the exact right target. We can map this out in various planes. So we can go closer to the midline, further away from the midline, more front, more back, until we found just the right location. And then that's where we put the DBS lead. So once we've got the DBS lead in, we test it, make sure that we're getting good reduction in your symptoms and no intolerable side effects. And then you're admitted to the hospital overnight and then usually sent home the next day. We then usually perform the pulse generator placement as a staged procedure, usually done a week or two after lead implant. We've found that, at least in my experience, the procedure itself, even though we do everything we can to make people comfortable and try to get through the operation as quickly as possible. We even have a massage therapist in the operating room that helps out to try to keep people comfortable. It's still pretty stressful. If you takes about 4 hours for the procedure, and by the end of that time, most people are pretty tired. And if we then go ahead and induce general anesthesia, which we need to put people to sleep in order to put the pulse generator in, a lot of times that can really delay the ability to recover quickly from surgery. So that's the main reason why we stage the procedure usually a week or sometimes 2 weeks after the lead implant. Then once we've got everything in place, we activate the system about a month after we implant the lead. And the reason for this delay is that whenever you place something into the brain, there's going to be, just like any surgery, there will be inflammation, there will be swelling, there will be changes in the tissue, there's tissue reaction that happens. And so we want to try to let that all resolve before we start programming, because if we begin to program and then those changes are still evolving or resolving, then the stimulation may, even though the stimulation is the same, the clinical results may be different. And so we end up just reprogramming over and over again. And so my general rule of thumb, and I think most people's as well, is just to allow everything to settle down before you begin the programming process. It's often difficult for people to wait because they want to see how things are going to work, and they want to try to get the benefit as quickly as they possibly can. But what I usually tell folks is this is a marathon, not a sprint. You're going to have the stimulator in for many, many years, and a couple more weeks is probably worth it in order to try to get the optimum result. this is an example of one of the earlier generation DBS systems. This is a Medtronic. This is the 3389 lead, which has been the standard deep brain stimulator lead that we've used for many years. In a minute, I'm going to talk about some other options as well. And it's the lead that we still use for the Medtronic system most of the time. This single channel Selectra pulse generator is, again, first generation. There's now been a couple new generations of devices since this Selectra, so I'll show you what that latest is. But this just kind of gives you a sense of scale of the size of the lead and of the pulse generator. And then this is what the whole thing looks like. Sometimes when I show people some of this hardware, particularly these caps, these burr hole covers that cover up the hole that we make in the skull and hold the leads in place, people ask whether those are going to be outside the scalp. But no, everything is implanted. There are no wires coming out. It's all underneath the skin. And the pacemaker is usually, this shows it on the left side, but normally, unless there's a reason not to, we usually put it on the right side. And it goes just beneath the collarbone, just over the pectoral muscle. And sometimes if the main reason we put it on the left side is if people are hunters or use a rifle or a shotgun very frequently. Because as you might imagine, if you're right-handed, you don't want to have the rifle stock or the shotgun stock hitting up against it. Okay, so that gives an overview of the process itself, and I think what we'll do is, you guys probably have questions. I know that there are some questions that were submitted ahead of time, but we'll probably hold on to questions until the very end, because I've just got a couple more things I'd like to show. So now that I've gone through the process, let me show you what's available in terms of the current generation DBS systems. So there are three manufacturers. There's Boston Scientific, there's Medtronic, and there's Abbott. Many centers have different preferences for which ones they use. I have for many years used Medtronic. I've used them since 1997. So in 1997, I was involved in the very first trials of DBS here in this country. It was a 10-center trial of DBS for essential tremor. And so since that time, I've been implanting DBS systems and have implanted somewhere over 700 systems during that time period, and have been very happy with the Medtronic products. They've been very reliable. They've done a very good job. But there have been some other, there have been some competitors, and there have been some things that have advanced. So I think it's worthwhile going through what there is now. So the main competitor to Medtronic, in my opinion, is Boston Scientific. They introduced this, what they call the Vercise pulse generator, which is now the next generation, which they call the Gevia, which has even more capabilities. And this compares it to the Medtronic rechargeable system. So I, in most cases, have implanted a non-rechargeable system from Medtronic, just because the recharger for the Medtronic system is pretty bulky. It's pretty difficult to use. It's hard to get it aligned with the pulse generator. And it wasn't until Boston came out with their charging system that I felt much more comfortable implanting a rechargeable device. It's also the smallest, device on the market. So it's, if you ever come in for a DBS evaluation, we can show you all the hardware and show you what the various different systems look like. It has some advantages. The battery life is 15 years, which is pretty impressive. I can't say that we've gotten out. We've only been implanting these for a few years, so I can't say for sure whether that's an accurate figure. It's obviously an estimate because we don't have anybody out 15 years, but that's pretty impressive. We usually tell people to recharge the devices for about 10 minutes per day, although the battery can last several weeks if you can't charge it. So people get worried, they say, well, the power outages and the fires and everything like that. Well, it turns out that you've got quite a bit of with the charger and with the battery itself, you've got a number of weeks, and probably 3 weeks is conservative, that if you're away from power for 3 weeks, you should still be okay. Another nice feature of this is that it has what's called 0-volt technology, which means that if it completely discharges for whatever reason, you can always wake it back up and get it started again. Sometimes if you deep discharge a battery, it won't work. So Medtronic's Medtronic's rechargeable system, if that happens to it, it's dead and you have to replace it. Whereas the Boston one, you can wake it up if you ever get to the point of it completely discharging. One of the things that's impressed me about it is that there are individual current sources. Now, what does this mean? Well, so you can apply electricity to, as you saw in the Medtronic lead, there are 4 different contacts on that lead. The Boston lead has 8 contacts, and you can apply electricity to any or all of those contacts. In a system like the Medtronic system, you can pick which ones are on or off, but you can't pick a percentage of how much electricity you'd like to go to that particular contact. You can do that with the Boston one. So it's very finely tunable in terms of the exact location that you want to stimulate. And you can also steer it. So there's the current lead, the current generation of lead that I use lets you steer the current in various different directions in order to avoid some of the potential side effects. There's a wider range of parameters. You can do all sorts of fancy things like have different frequencies for different parts of the lead. So at the higher part, you could have a high frequency. The lower part, you could have a low frequency. So it's got all sorts of kind of fancy features that if we want to try to get creative with our programming, we can do so. And it is MRI conditional, meaning that you can have a 1.5 Tesla MRI scan at under certain circumstances. Almost all systems now are conditional at 1.5. I will say that I think we may only have one 1.5 Tesla scanner in the hospital at Stanford. All of ours are 3 Tesla. What Tesla refers to the field strength of the magnet, which is how powerful the scanner is and how good the images are that you can obtain from it. So there aren't many 1.5 Tesla scanners around, at least at Stanford, but there are in other locations. So you can usually find a 1.5 Tesla, but they're becoming less common. This is what the whole system looks like. So there's the pulse generator. You can see the leads. There's 2 different ones. The one in the back has 8 linear electrodes, and the one in the front has segmented leads in the center. So you can see this better on the display above, which is the clinician programmer. So this is, when we're programming the DBS system, this is what we look at. And what it's showing here is that we've got 2 of the 3 contacts in the middle of the lead activated. And you can see that there's fractionation of the different the different electrical current on those different leads, so that we can make a very asymmetric electrical field, and that's shown on the middle there. You can see the lead and the electrical field is indicated in red. So it's really quite nice in that we can visualize what we're doing, we can steer it around, we can check for side effects and make it as effective as possible with the fewest side effects possible. And there have been some very good studies on this showing that indeed you can get better results by using this current steering and by using the differential current sources. And then on the right is what the patient programmer looks like. So it's, you know, not too far different from the Medtronic one. It's maybe a little bigger. I think maybe a little ergonomically better than the prior generation of Medtronic. And then this is the charging system, and this is the thing that I really like about it. It's really easy once you get the hang of it. It does sometimes take a while to get the hang of it, but you take this device, this puck, you put it on a charging base until it's completely charged. Then you take it off the base, and it's you know, very convenient. The base stays plugged in all the time. You take it out, put it in this little pouch, which then position over the pulse generator. It beeps, and then it stops beeping when it finds it. And then once you're fully charged, then it stops beeping. So it actually seems to work really, really well. And it's much more ergonomic and convenient than the Medtronic system. Okay, so that's the Boston system. Now, you know, Boston came out with this system a few years ago, and Medtronic had been working very diligently on a research version of the system that we're now currently using, which I think also has some very exciting possibilities. So this is called the Percept, And that's the device on the right side as compared to the one on the left, which is the old tried and true Activa PC that we've used now for probably 10 years. So it's a reliable system that works very well, and many people are familiar with. Some of the advantages of the Percept: it's smaller and it's thinner than the Activa. It's not a huge amount smaller, but it is smaller enough that it's noticeably thinner and noticeably smaller, and it's got nice curved edges. So one of the problems that we've seen sometimes with the Activa is, particularly in people who are thin, it can poke up against the skin and cause irritation or erosion through the skin. They have a rechargeable version, but this one is non-rechargeable. And I think my general approach is that if somebody is interested in a non-rechargeable system, says, you know what, I know it looks convenient, I don't want to deal with charging, I can't even remember to charge my phone. I sympathize with that, and I say, yeah, I get it. I might be that way myself. And so this now gives us a very nice option for people who want a non-rechargeable battery, a non-rechargeable option. The good thing is you just set it and forget it for the most part. You don't have to do much with it. It has this really neat sensing capability, which I'll talk about in a minute. And this came out of Medtronic's research program, which has been ongoing for many years, and that we've participated in Stanford very actively. The cool thing is that in the future, it's in the firmware of the battery, we may be able to unlock the capability for it to sense neural signals and then change the stimulation based on the state of your brain. So that's something that this would be the only DBS device to offer that, which would be really neat. It's not available yet, and we don't tell people that it's coming anytime soon, because we're still learning about what signals we need to sense and how we deal with them. But it's a really tantalizing, really neat opportunity, and a lot of people recently have been pretty excited about it, and particularly those who are coming in for replacements of their pulse generators with a Medtronic system. There's a way that we can hook them up to a Boston system, which people have done successfully, or we can go back to a Medtronic, and this provides a really nice, a really nice option for that. And the other really good thing about this battery is it's MR conditional up to 3 Tesla. So this works with all the clinical scanners that are currently available. So it's quite MR compatible, and so that's another particular advantage. This is an example of the Medtronic clinician programmer. It's on the left is the patient programmer. So it's like a Samsung phone. So it's a familiar form factor. And we'll look at that a little bit more here in a second. But this is really neat. This is actually one of our patients that we have analyzed using this, what's called brain sense, is what they call it. And so this is between these two contacts, contact 8 and 10, as you can see on the right side, and looking at the particular frequencies of the brain signals. And what you see there is there's this, the blue line at 13.67 hertz, or cycles per second, is in what's called the beta range, which is a particular range of oscillation of the brain that we found to be, Dr. Bronte Stewart and her team, and I've been involved in this research as well, have found this to be quite well correlated with Parkinson's symptoms. So increase in beta means increase in symptoms usually. And so we're doing ongoing work to try to better characterize this and to see if there's a way that we can use closed loop stimulation to try to do a better job of stimulating just when it's needed, extending battery life, and potentially reducing side effects. So these are some examples of the things that you would see on the programmer. On the left side, you can see how much battery charge you have. You can see whether the therapy is on or off, and you can change the settings if we give you the ability to do so, all quite easily from this touchscreen interface. You can also change. We can change if there are particular side effects. For example, let's just say that when you're walking, you need a little bit higher voltage, and let's just say that higher voltage impacts on your speech, like you may not be able to talk as well with that higher setting. You could set it so that it's optimized for one particular use, like walking or talking, or other types of things. So you can easily pick and select which condition you're in and what you want the stimulator to be doing at that particular time. On the right, you can also mark events so that if your neurologist is saying, well, you know, I'd like to follow this beta range of your brain signals. So please, over the next day, tell me when you take your medication, if you're exercising, if you're having dyskinesia, if you're on, if you're off. And we, as clinicians, can set up those events in the programmer, and then you can tell us over time, and it'll set markers, and it'll record a little snippet of brain activity that'll tell us what's going on in your brain. So this system has a really nice ability to sort of peer into the deeper functioning of the brain, both for research and hopefully for clinical improvement at some time in the near future. Okay, so what are the outcomes? Well, you know, I think people are probably fairly familiar with this. There are, of course, the potential for bleeding, which can happen up to 1.5 or even more %. You can have very, very bad hemorrhagic complications. It can look like a stroke, and that happens in less than 1% of patients. Thankfully, it's quite rare, and throughout my career, there have only been a handful, 4 or 5 patients who have had very bad outcomes, despite having done, as I said, over 700 operations. Infection still unfortunately happens, maybe between 3 to 5% of the time. Stimulation side effects are fairly common, particularly during the initial programming. They can consist of things like tingling, muscle contractions, double vision, speech difficulties. We can usually program around those things. There are some common recovery issues in DBS. People frequently complain of fatigue, and this can last a while. It can last up to a few weeks. Also confusion. These two things are something to sort of be alert for. They can happen, and they frequently do. They're almost always temporary, but in some cases, things like confusion or cognitive trouble can be permanent. But in the vast majority of cases, they're temporary. Headache, pretty common after having had an operation on your brain, and we do, cerebrospinal fluid does escape, and so that can also lead to a headache. And believe it or not, people are pretty impatient with the programming, as you might expect. It's like, well, why am I not better right away? It often takes a long time to optimize those settings, and so it's important to have patience. Let your neurologist adjust the medications, you know, turning the medications down as you turn the DBS up. And then there's always the question as to whether or not to have some rehabilitation, which, you know, sometimes when you've sort of gotten used to having your muscles work in a certain way, and the DBS is now providing you some relief from some of that, sometimes some retraining is absolutely worthwhile. And then this is just some of the aggregated numbers from many of the studies that have been published looking at the reduction in many of the symptoms. So 60 to 80% reduction in tremor, about a 70% reduction in rigidity, difficulty with movement, about a reduction of 55%, gait also about 55% reduction, and about a 60% reduction in postural stability. Probably the best way to illustrate this is just with a video. So if you'll indulge me in a brief 5-minute video that this was done many years back. This is a patient of mine from the Cleveland Clinic. And so I'll just let this run, and hopefully this comes through okay on the video and you can hear it all right.
I was first diagnosed with Parkinson's in May of 1995. It just overtakes you. Everything revolves around my Parkinson's, it seems.
In this home video, Art Davis documents what had become a daily struggle with Parkinson's disease. He is 57 years old, but the effects of the disease had reduced him to a state of near infancy. Some days he was barely able to move, or there were the moments when his body was plagued by uncontrollable, erratic movements. He never knew which to expect. Medication no longer helped much. The only certainty in Art's life was that the symptoms of the disease were getting worse.
Which one are we going to?
Left or on the right.
It's 6 o'clock in the morning, and Art is facing hours of surgery. He is off medication and barely able to move.
that I hope to be able to do things that I haven't been able to do. This disease has just consumed me over the last 8 months. The first few years, I was in control, but for the last year, it's been in control.
A couple of hours later, a team of surgeons are hoping to give Art some of that control back by working deep inside his brain. They begin by isolating the area in the brain responsible for the onset of Parkinson's. Art is awake for almost the entire procedure. The brain feels no pain. The surgeons have found the spot now where they need to be. They implant an electrode which will deliver a continuous electrical impulse to Art's brain and inexplicably ease his symptoms.
Let's go to 2 volts.
They experiment with a small amount of current in the operating room. Art is given some instructions to see if the stimulation has any impact.
And close and open. Close all the way and open. Fast as you can. Look how. That's fantastic. Very good. Fantastic. Good. Tap your finger like this. Big and wide now. Big and wide. Could you do that before when you're off? No.
The surgeons feel good about the way things are going so far, and so does Art. The nurses put his wife on the phone to hear the good news.
Having some good results. We're having real good results. I'll be able to chase you around the yard.
Okay, good. That's great.
The team's spirits are high, but the outcome is still uncertain. Once the surgery is complete, Art will spend the night in the ICU to make sure there are no complications. A few more rounds of surgery will complete the implant. And we are back. With me here tonight is Dr. Jamie Henderson, who we just saw at the other end of a piece of scientific equipment. And we are happy as well to say with us here tonight is Mr. Art Davis. Got some complaints for chasing your wife around the yard. When you look at that piece of videotape, that's you, and yet it must feel like an out-of-body experience.
Yes.
What does it feel like now, knowing that was still you then, but you had absolutely no control over your musculature?
I feel 20 years younger. I've not had one bad moment since I've had the surgery.
Okay, so I mean, of course, not everybody will have as good a response as Art, and not everybody will have no bad moments since the surgery. But I would say you know, a fair number of people do really quite well, and for many people, the question that they often ask is, well, why did I take so long to have it done? So just to wrap up, and then we'll take some questions. You know, I've been impressed over the years with the ability of STN DBS and of course GPI DBS to improve all the cardinal signs and symptoms of Parkinson's. I think as time has gone on, we've continued to improve the targeting, refine our procedure to improve patient comfort and produce better outcomes. The manufacturers have been working right alongside with us to provide us with more capabilities for the systems. You know, we've got all sorts of things that we can now do, and I would say the field is still in its infancy. You know, where there's still so many things that we can learn about the brain, and so many ways that we can, you know, really design systems in the future that will do even a better job of treating the symptoms without producing side effects. And in fact, you know, we've just started a new consortium at Stanford, the Neural Interfaces Innovation Center, that is working with engineers, scientists, and clinicians to work towards the next generation of devices. And so Dr. Bronte Stewart and I head that up, and we're very, very excited about the possibilities of the next generation of DBS at Stanford. So if anybody wants more information, Erica Lim is the nurse who coordinates my clinic, and she can be reached at this number if anybody has any questions or inquiries. So I'll leave that up for a second so people can write it down. And, you know, maybe we can, let's see if I can, there we go. All right, so. Are you guys still there?
Yeah.
Okay, good. All right, great. Excellent.
Yeah, thank you. That was excellent. Very thorough, particularly what's available now, you know, pretty much right now. So that, thank you for bringing all that current. We did have one question that came in so far.
And maybe while you're looking at that, maybe I can just answer. I know we had some pre-questions.
Sure.
And I think I probably answered most of these, but I will sort of go through some of them as well. I do want to get to that question soon. But I think an important one is what precautions are being taken for DBS surgeries during COVID-19. I think that's a really important one. And we've been able to restart at Stanford doing these surgeries by testing everyone who comes in. So every patient who comes in gets tested ahead of time before they come to the clinic. And they have to have, I believe they're doing another test even prior to the surgery itself. We do a daily symptom check. So we do a daily check-in with Stanford so that we're all considered to be safe. I've had a COVID test, which is negative. And so, we're doing our part to try to keep everybody safe during this time. And I think we've got a very good track record. To my knowledge, nobody has turned positive. I know none of my patients have turned positive in the hospital or during their assessment or evaluation. So, maybe we can take your question, Stephen, and then we can maybe go back and forth for live questions and the ones that we got.
Sure. Sure, and it's actually something we hear all the time that Robin and I hear about people who are interested in DBS. Is there an advantage to waiting now? And we just saw quite a few really exciting things happening. Waiting for a better version to come along. And is there any age limit, young or old, for DBS? And is there a time limit maybe from the time of diagnosis to when DBS might be appropriate?
Yeah, three great questions. Question one, should you wait? Well, with the two, so I didn't talk about Abbott, and the reason why is I haven't worked with them. Their system, I think, is probably a little bit behind technologically. So I don't know if there's anything on the horizon with them. I know that both Medtronic and Boston have had a big push to try to get these latest, greatest systems out. The FDA often takes a while to approve anything. So now's a good time because these really are sort of the state-of-the-art systems, and there's nothing that I know of that's maybe super exciting that's coming down the pike. But companies are always developing things. It's kind of like the latest computer, right? Should I get one now, or should I wait for the next iPhone or whatever? I think if it's appropriate, if your symptoms are that the time is right for you, if you're a neurologist and has decided it's right for you, then I think go for it. Age limits, there's no hard age limit. I've implanted people as old as mid 80s, 86 I think has been my oldest implant. The older you get, the more your complications. It's probably not a linear relationship, but it clearly is. It clearly affects it. Some of my patients who have had some of the worst complications have been older than 80. So I don't put 80 as a cutoff, but if someone who's older than 80 wants it, then I have a very careful conversation with them about the timing of the surgery and whether or not they would be able to tolerate it. In terms of time since diagnosis, it's really variable. It depends on the individual. So I would say probably the average is about 10 years after diagnosis. And the reason I think for that is that's when people start to develop side effects from the medicine, or the medicine is no longer as effective. So, there have been some studies looking at earlier intervention in DBS. I don't know that there's been any clear recommendation that we should do that. My own sense is that if it were me, so if I developed Parkinson's, I'm in my late 50s, and so if I developed Parkinson's tomorrow, or was diagnosed with it tomorrow, I would of course begin medication, but I probably wouldn't wait very long, because I think that earlier intervention although it's never been proven to have a preventive or a beneficial effect on the disease itself, I think the brain kind of learns to be Parkinsonian. And if we can intervene a little on the earlier side, I think it's often better. But that's not been proven out by any sort of research. So I think it's an individual choice. It's a choice with the patient, with the neurologist, and with the care team. I do want to get to the question of whether we do awake and asleep DBS surgery. The answer is absolutely yes. I have experience with both techniques. Myself and my colleague, Dr. Halpern, have actually written a little review article on awake versus asleep DBS, and there's no clear benefit to one versus the other that's been shown in the literature. And trying to do a head-to-head comparison of those techniques would be really tough to do. You'd have to have lots and lots of patients, and finding a difference between the two would be difficult. My own preference is to try to do it awake, and the reason for that is because we know right away during surgery what the side effects are going to look like, and so it can give us some hints or clues as to which way to move it. We do in the awake surgeries, we often make more than one pass through the brain in order to get the optimal target. In the asleep surgeries, we also, I would say, at least probably 20 to 30% of the time will move based on the imaging that we take during surgery. So the asleep ones are guided by imaging, the awake ones are guided by physiology or guided by the patient. So I think those two things together, either one is good. So I don't have a strong preference, but my at least slight preference would be to do it awake because we get more information. So then maybe back to if there's any live questions.
Let's see, I don't think, we actually haven't had any. So you mentioned you don't see much of a difference in the outcome asleep or awake as far as functionality for people after
Right. Yep, there's my own just sort of intuition about it has been the patients seem to do pretty well both ways. And our review article looked at a lot of different articles in literature. So basically took all of what had been published in the literature and looked at it. And there wasn't any clear-cut benefit to one versus the other. But just from a theoretical standpoint, I do think that I personally prefer the awake version. There's a question asking, could we speak about the screening process that's used to determine if you're a good candidate for this type of surgery or not? So, at Stanford, we have patients undergo what I think is a pretty rigorous screening process, which I'm very happy with. So we would have you do an on-off exam, which means to come in off medication and then another day on medication. So what this does is it tells us how bad are you at your worst and how good are you at your best. And that differential gives us a good sense of a couple of things. One is, do you really have Parkinson's disease? Because sometimes people may have something that looks like Parkinson's disease but isn't, and we call those Parkinson's plus syndromes. And if you've been taking medication over the years and the medication doesn't seem to have been doing very much, and we take you off the medicine and you don't change, that gives us some indication that maybe maybe you might not have Parkinson's, and so that might require a little bit more investigation. And it also gives us kind of an idea how your medication response is. And there's a tendency for better medication response to be associated with better DBS response. And so if you respond well to medicine, if you've got that on-off differential, if you've got fluctuations throughout the day, we can even out those fluctuations, bring you up closer to your on time more often. And having that on-off exam is really helpful. We then do neuropsychological testing, and the neuropsychological testing is important to be able to give an idea of whether or not there would be any sort of changes in memory or verbal processing or the ability to do multitasking or visual spatial skills. If you already have some problems in those areas that are revealed by the neuropsych testing, we might very well make those worse with surgery. So that gives me much more information when I talk to you to be able to say, look, here's the areas that we might be a little bit concerned about and why you may want to really think carefully about undergoing surgery. So I think that's kind of the And then once we've got all of that information, at Stanford, we review that in our multidisciplinary surgical review board meeting. So in that meeting, we have neuropsychologists, neurosurgeons, neurologists, and a speech pathologist and various different people. So, we do have quite a few different, quite a few different people at that meeting to help make an interdisciplinary decision.
Okay, we have actually had a couple of new questions. How effective is DBS on reducing freezing of gait?
Yeah, so it's so this is an area that Dr. Bronte Stewart at Stanford is really interested in. She does some testing called dynamic posturography. And with this, there's a whole host of things that there's like a balance machine and gait testing and various different things that she does. And so there are, interestingly enough, a number of different kinds of gait disorders in Parkinson's. And there are certain types of those that if you undergo that particular testing, that we can sort out the ones that are going to respond best to surgery and not. From just sort of a 30,000-foot view, what I can say is that early in the course of the disease, DBS often works pretty well for freezing of gait. And this is, parenthetically, this is also where the closed loop system may come in, because there seem to be different frequencies that are associated with gait freezing that we might be able to do better with in stimulation. But later on, it tends to work less well. So it's one of the things that we can reduce tremor, we can reduce rigidity, but some of the things that sort of aren't as well treated later on, one of them is gait. So that's something that's pretty variable, and it varies patient to patient. We're starting to learn more about what those characteristics are of who's going to respond and who isn't.
You touched upon it. Do you have an idea or a guess, very educated guess, on when the closed loop system might be approved? I know how much testing you guys have been doing, so.
Yeah. No, well, there's currently an ongoing multi-center study now that's looking at closed loop neurostimulation. So, I think once that study concludes, or even maybe, at some point during the course of that study, we may see it. I'd say it's easily a year off, most likely, at the minimum, but probably not 5 years. So I think it's kind of in that realm of in the 1 to 5 year range that we'll begin to get enough data that it's worthwhile to unlock that capability in the pulse generator.
Good. One person mentioned they're having trouble enunciating certain words, actually producing the speech. Does DBS help with? They asked specifically about the facial muscles. Would it help with control of those, do you think?
Yeah, unfortunately, no. Speech is one of the things that DBS doesn't help. There are a few things, speech being one of them. Troubles with blood pressure, some of the non-motor things, sleep issues, troubles with your thinking, blood pressure fluctuations. So there are a lot of things that don't respond to DBS. So it's important to know that. So yeah, unfortunately, no.
Yeah.
It can get worse with DBS.
We had a previous question, and I see someone kind of asked a similar question about reduction of medications after DBS. Friends I know who've had DBS had considerable reduction in their medications. As the disease progresses, sometimes they have to bump that up. How do you approach that? How do you think about that? And how is that expressed to the patient? Yeah,
one of the big differences between targets, GPI or globus pallidus is a widely used target for DBS, as is subthalamic nucleus, STN. And one of the differences between those is that with STN stimulation, you can often reduce medicines by somewhere in the 50 to 60% range. Whereas with GPI stimulation, you can sometimes reduce medicines, but often not quite as much. So that's, one of the advantages of STN over GPI stim. On the flip side, it's felt that maybe GPI may be associated with fewer cognitive side effects, although that's never been shown to any significant degree, but it's sort of a hunch. So oftentimes, if we have someone who we're a little bit more worried about cognitive side effects, we may choose a GPI target, knowing that we may have to have higher medication doses, but also realizing that sometimes it's the medications that are causing some of the cognitive problems. So, it's a real chicken and egg problem that I think having a good integrated interdisciplinary team like we have at Stanford to really approach the problem from all sides can really tease those things apart and choose the best target for the patient. So it's kind of a long answer to what was a simple question, but
it's one thing that I know many people focus on for DBS is that I won't have to be taking quite so many medications. It's quite so often anyway, so great.
And in fact, there are a few patients who can, we've had some people get completely off medication, and that's, that in Europe, they do that frequently, actually. They take people completely off their meds. My own bias is, I think, a little bit of medicine, maybe just a little Cinemet, much less than you were taking before, just to sort of prime the pump, as it were, just to kind of keep things moving. I think people often do better with just a little medicine rather than none whatsoever. But I've had a number of patients who said, I hate medicine so much, and now with DBS, I don't have to take it. So, everyone's, again, individualized per patient. But I heard somebody say this before, and I think it's just so true. Parkinson's patients are like snowflakes. Everybody has their own unique version of the disease. And so you really have to have the ability to individualize medication and stimulation for each person.
We talked a little bit about speech and some of the other side effects. Somebody asked about behavior. Have you seen some behavioral changes?
Yeah, unfortunately, it's uncommon, but unfortunately, some people can have, behavioral changes in terms of being, associated with cognition. And in the worst cases, it could be as bad as, having almost like a dementia-like picture. Thankfully, as I said, that's rare. Less than 1% of patients will have something like that. But when it happens, it can be pretty devastating. So I think over the years, we've gotten better and better at targeting, better and better at tailoring stimulation and trying to, improve the procedure so that happens less frequently. But yeah, it can still happen.
Okay. Someone asked about focused ultrasound as a treatment option. They also continued, I know you answered this already, if DBS is completely reversible. And then if there's side effects that the patient decides they can't live with.
Yeah, so, DBS, we believe, is reversible. I've had, patients. The thing is, nobody has them taken out, so it's hard to know for sure. We assume that it's reversible, but it's so rare for people to have their DBS removed that it's hard to say. But on some occasions, when we've had, like for example, in the rare case where the DBS leads get infected, which is again, very, very rare, and we have to take the leads out, treat with antibiotics, and then maybe reimplant them. There have been some cases where, someone would say, for example, I was having a little bit of speech trouble with the leads in, but now my speech is better, or something along those lines. So there probably is a very small effect just from having the lead in place. But that does reverse. So I don't think there are any permanent irreversible effects, depending on the patient, but we don't have enough data to really know for sure. And then the focused ultrasound part, I thought about including a piece on focused ultrasound in the talk, but decided against it since it seemed kind of long already. But long story short, we are doing focused ultrasound for tremor, for Parkinson's tremor. It won't help the other signs or symptoms of the disease. We can only do it on one side, but it can be effective for tremor. We've also been participating in a study of GPI ablation using the focused ultrasound, which is ongoing. I think we're just wrapping that study up, so we'll see what the results of that end up being. It's a multi-center study similar to the original focused ultrasound for tremor study was. And so, you know, we'll see whether that's a good treatment or not. So it's an exciting technology. It's non-invasive. You know, it's a single treatment rather than having to come back all the time. But the downside, of course, is if you have a side effect, then it's permanent, most likely.
I don't think I see any other new questions. I know one of the,
So
I was just going to say, one of the questions we had from previously was about the pre-surgical testing process. Is any of that happening with telemedicine?
well, yeah, we can do at least the initial assessment via telemedicine. But in order to really assess you thoroughly, you have to be able to feel rigidity. You have to be able to, you know, interact with someone in person to really get to know them. So while some of the process, at least the early parts of it, can be done remotely, it's still a pretty intensive process, I think, to do the proper assessment, to have people come in and be fully assessed.
Okay. And how about programming by telemedicine?
That'd be great. Yeah, the manufacturers are working towards it. I know Medtronic is really working hard on trying to have a telemedicine method for this, because I think they were the ones who may have pioneered it on the pacemaker, cardiac pacemaker side, doing remote programming. So I think there is a push to try to do more of that remotely, particularly in the current times when so much is being done, you know, with Zoom and, you know, virtually. So I think that's, I think it'll be great to see how that goes.
Okay. Did you have anything else that you wanted to share with us?
Yeah, I just want to make sure that, you know, I think we've gotten really to all the questions. I think, you know, probably many on the line are well informed, you know, have been following DBS for a while, but hopefully I've provided something a little bit new to think about. And again, we're here if you have any further questions. Erica's number is 650-721-4936, which hopefully those who had the opportunity to write it down could. And I'm sure if, you know, getting in touch with you, Stephen, or with Robin, we could get more info.
Sure, absolutely. We're here to help with anybody's needs related to Parkinson's, including deep brain stimulation. So, and again, just as a reminder, anywhere in Northern and Central California. So we definitely work with all the Stanford docs, but all the other centers, and we're very fortunate in this area to have lots of excellent surgical centers for DBS. So I remember one of the doctors that I used to work with said if you have to have Parkinson's, the Bay Area is probably the best place in the world to find resources. So
yeah, we have great resources here. We have two great medical centers, you know, Stanford, UCSF, both terrific. You know, so, you know, and I just saw somebody quickly asked what the waiting list is like.
Oh yeah.
Not very long. You know, I would say, you know, we can get people scheduled within a month or two. So it's, you know, it's a lot of it is just going through the process, but you know, we can get things scheduled fairly quickly.
Yeah, and I see someone asked about machine learning and Parkinson's. Do you know any studies?
Oh, yeah. Well, interesting. That's another hour talk, I would say.
Yeah.
Just
We'll schedule.
How do we leverage all the data that we have and really learn how to do things better? So great. Well, yeah, thanks very much for having me. I really appreciate it. It's been
we're
great.
getting lots of thanks from the viewers too. Thank you. It was a great presentation. I do see one question that I actually hadn't thought of before. What happens if the patient suddenly moves while you're doing surgery? I see, you know, you did a great discussion of what happens at the head level, but we have Parkinson's. So.
Well, all I have to say is that in, you know, over 700 operations, many of those, you know, 500 at Stanford, all frameless. I've never had that happen. I mean, people are usually, if people adjust, if they're adjusting their position or something, I'll often say, if we're doing something delicate, I'll say, hey, could you hold still for just a minute, while we're doing this, like when we're making the very delicate incision and the coverings over the brain, that's a pretty delicate time, but it only lasts a few minutes. So for the most part, most people can sort of move their head, move around. It's all pretty tolerant to that.
Actually, we just had one other question. If I have DBS, how long should I plan on taking off from work?
That's a very good question. I tell people 4 to 6 weeks.
Okay.
4 to 6 weeks is pretty good. I can't tell you the number of people who said, oh, I'll just go to work next week. This isn't going to be much. And I'm like, it's an actual brain surgery. You may want to take a little bit of time.
Yeah. Okay, I don't think, you're getting lots and lots and lots of thank yous. So thank you very much. I don't see any other questions. Please reach out to me if you do. I put my email address in the chat box. Please reach out to me.